Good morning or good afternoon to you all. I'm Krista Thompson with ClearTriage, and I'm so excited that you all have joined us today for our very first 10 for 10 webinar with Dr. David Thompson. Just a couple of quick housekeeping things before we start our conversation today. So you should see a chat button at the bottom of your screen. You can use this to message a member of our team today. If you have any questions or just a general message, please drop that in the chat. If you have questions for our presenter, they will be forwarded to him after the webinar today. A recording of this webinar is also going to be available after the conclusion of this session at cleartriage.com on our blog, so you can check that. We will also be sending out an email when that's available. And then lastly, I hope you're not, but if you're experiencing any technical issues, please go ahead and message us using that chat button, or you're welcome to email us at support@cleartriage.com. So without further ado, I'm going to stop sharing and we will turn our cameras on here. And then we're going to go ahead and just jump into this conversation with Dr. Thompson. So again, let's see, there we go. Well, welcome, Dr. Thompson. We are so excited to have you here. We're excited to welcome you. And for those of you joining us, Dr. David Thompson is board certified in both internal medicine and emergency medicine with over 30 years of clinical and leadership experience. As one of the two senior medical editors at Schmitt-Thompson Clinical Content, he has led the development of widely used telehealth resources, including the adult after hours and adult office hours nurse telehealth triage protocols that are used within ClearTriage. His work also includes development of Symptom Checker, HealthBot, consumer engagement, natural language processing, and telehealth applications. He performs benchmarking work with medical call centers, aggregating data from more than 6.5 million telephone triage calls. A prolific author and speaker, he has made lasting contributions to global healthcare in the areas of telehealth, quality improvement, and patient-centered care. We are so excited again to kick off this 10 for 10 webinar speaker series with you, Dr. David Thompson. So welcome, Dr. Thompson. Welcome to all of our attendees today. We're so excited to have you guys with us.
Well, thank you very much, Krista. It's just a pleasure to be here, and thank you for such a fine introduction. You know, before we start, perhaps I've got a question for you, if that's okay.
Absolutely.
You know, Krista, we share the same last name, Thompson.
We do.
Are we related in some sort of way?
I am so glad that you have asked this, Dr. Thompson, because I get this question quite a bit when I am meeting our customers and folks for the first time. No, we are not related, though we do share a last name, but there is no relation there.
You're right. There's no relation, but it's a pleasure to be with you here today. Let's you've got a bunch of questions for me today. Let's jump into it.
I do. I'm so excited. So to get started, I think we all just kind of want to learn a little bit about your career and what kind of got you started. So what influenced you most in your early medical career?
That's a good starting question. You know, someone once said, Krista, that life is a journey with problems to solve, lessons to learn, but most of all, experiences to enjoy. And I tell you, it's been a great journey. This pathway that I've taken through college, medical school, then residency training, 35 years working as an emergency physician, and gosh, now 25 years authoring telehealth triage guidelines. In terms of people who influenced me in my early medical career, you know, there were so many fine physicians that provided excellent mentoring, coaching, instruction, and modeling that I internalized all along the way. I remember my first medical school clinical rotation at Cook County Hospital, working in the wards of general surgery. I remember Dr. Olga Jonason, her stern authority, intelligence, and high expectations. I remember so many good role models during my residency also, physicians who were strong clinicians and also strong leaders, doctors like George Del Castillo, Dr. David Zoll, Dr. James Matthews. I also learned from my physician peers during residency, doctors, for example, friends and colleagues, Dr. David Dansky and Dr. Craig Rosenberg. We learned together in the ER. And of course, even then during my residency, I learned so much from the nurses in the emergency department with whom we worked side by side. And I continue to do that even today. I'll also call out my first emergency medicine job. This is many years ago. I worked at McNeil Hospital with Drs. Alan Spicone and Dr. Jeff Schwartz. And I think they were the ones who first introduced me to this idea of using technology to improve clinical operations. So many positive influences that have helped me along the way. So good first question.
Yeah, no, it sounds like it for sure. And so you're talking about kind of that early history in your medical career, and your career could have taken many paths, right? What drew you specifically to nurse triage protocols?
Well, actually, Krista, my career has taken many paths.
That's true.
In addition to emergency medicine for 35 years, I've had a number of other work experiences that have positively influenced the way I think about and approach authoring, editing, and trying to continually improve our guidelines. Looking back on some of them, as far back as 1991, I first developed a software program called Chart Review while working as an ER physician. And it could read through hundreds of ER records per minute, filter them out by diagnosis and date range, and then actually do documentation checking for the physicians for quality assurance measures.
Wow.
I served as the medical director and chair of the McNeil Hospital Emergency Department for 5 years. And in that role, I worked on systems, policies, procedures to improve clinical care and patient safety. I served as the chief information officer for a large physician group, large physician staffing company, and had responsibilities for technology development, data analytics, and benchmarking. And I served as the chief medical officer for a large physician billing company that billed for close to 2 million patients a year, over 1,000 physician providers that we billed for, and had had educational oversight for all physician documentation and compliance issues. Going on, I founded a digital health company that created software for natural language processing, triage chatbots, and diagnosis symptom checking. And lastly, I've been on both hospital-based and national quality assurance committees, which have influenced the way I think about our approach to quality. So kind of a long answer to your question, but lots of different things that have helped get me to where I am currently.
And so to follow up on that, so how did you initially become involved with the nurse telephone triage protocols? What inspired your interest? How did you start that work with Schmitt-Thompson, with Dr.
Well, in 1995, so that's a few years back, I was working in the emergency department at McNeil Hospital, serving as the medical director and also the chair of the Department of Emergency Medicine. And it was a good time to be there. McNeil Hospital and Health Network was located in the western suburbs of Chicago, and it was going through a bit of a renaissance. We had very enlightened leadership who were trying to do some new and innovative things. We had a fantastic medical staff, and the physicians in the emergency department at the time were some of the best physicians with whom I worked. The nurses in the ER were also excellent. Many medical call centers got their start in the mid and late 1990s. This trend was facilitated by advances in telephony and also computer hardware technology, which in turn made possible for the first time certain types of software applications like medical call center software.
Mhm.
And our emergency department leadership, working with the executive leadership of the hospital, we put together a written plan for launching a medical call center at the McNeil Health Network. And in 1996, we launched a 24/7 full age range medical call center. Tony Noska, who was the assistant nurse manager of the ER at the time, became the manager of the department. Tony and I, plus a great group of emergency nurses, jumped into this project enthusiastically. We did what everybody has to do. We wrote detailed policies and procedures. We developed an onboarding program for training in the software and clinical processes. We set up a QA committee and quality improvement audits. So that was the start.
So when did you first meet Dr. Barton Schmitt?
Well, this is the important part. This is when I first had the opportunity to meet Dr. Schmitt. So in 1996, there was a new and growing company that had a software program that could be used for performing telehealth triage in medical call centers. The software company's name was National Health Enhancement Systems, or NHES, and the software program was called CentrumX. CentrumX was one of the first programs to store, display, and allow nurses to interact with the telehealth triage guideline. There were two sets of content in the software. The pediatric content, of course, was written by Dr. Schmitt, because even at that time, Dr. Schmitt or Dr. Bart was well recognized as being the predominant physician clinician leader in this area, and was and is considered the father of telehealth triage. In preparation for launching the McNeil Medical Call Center, I took it upon myself to recruit a group of ER, primary care, and specialty physicians to review every single one of the pediatric and adult guidelines that were present in the software. We printed them all out. We put them into large 3-ring binders, and then we distributed them to our work group. I had the chance to read through all of them. Back in 1995, there were many fewer guidelines, but still between the two content sets, there was close to 200, maybe over 200. We went through the guidelines, we marked them up with red and blue pens, and we met as work group, and then finally customized the guideline, made edits within the software, which was quite difficult at the time. Now, here's 2 points. First, Dr. Schmitt's pediatric guidelines, when we read through them, were just excellent. Of the over 100 guidelines, we made only minor changes to a handful. They were just great.
Mm-hmm.
However, the adult guidelines were written by a health information company not affiliated in any way with Dr. Schmitt. They were much weaker in clinical decision-making, care advice, and just common sense. So our work group ended up making substantive changes to probably over 90% of these guidelines in the weeks and months prior to launching the call center. So I believe it was during this period, or perhaps just shortly after launching the call center, that I first contacted Bart and benefited from his deep expertise and his calm authority. So there you go.
So how did you start working with Dr. Schmitt then to start? So you've told us how you met, but then obviously there's been development since that meeting because of where we are now. So how did we get to the point where you actually started writing those guidelines?
So Krista's asking me to expand, so I will expand.
I am.
Yes. So 4.5 years later, in 1999, the administration of our hospital decided to close down our medical call center. The call center had been, frankly, very successful from a clinical operations standpoint. We had a 24/7 call center. We implemented a number of innovative programs such as asthma disease management and pregnancy support. We had a needle stick hotline. We worked closely both with their new health maintenance organization as well as the ACO that they had. However, the hospital was located in an urban area, which means that there was many other hospitals in close proximity, and it was very difficult to prove return on investment because of the natural flow of patients to nearby hospitals. So they closed the call center in about 1999, and one day, shortly thereafter, a lady by the name of Sue Altman gave me a phone call. Sue was a warm, energetic, and super bright early leader in this growing field of telehealth. She contacted me on behalf of Dr. Schmitt, and she approached me with the idea of developing an adult content set of telehealth triage guidelines that would be as clinically robust as BART's and have a parallel structure and organization and logic. And I spoke with Bart at length shortly thereafter, and as they say, the rest is history.
That's amazing. Well, thank you, Sue, wherever Sue is.
And thank you, Bart. So
Thank you.
yes.
Yes, of course. Thank you,
Yeah.
Dr. Schmitt. But yes, that connection was huge. So how did your skills and expertise complement and build upon that initial work that was done by Dr. Schmitt at that time?
Nice question. Bart and I share a number of interesting and important areas of skill and background. For example, and maybe you know this, but both of us trained in engineering before medical school. And as a result, we have a similar analytic approach to thinking about and developing the complex algorithmic logic that is required to successfully have telehealth triage guidelines that support patient safety. And further, we both just enjoy this process. And when I was first started working with Bart, he was already well known and well established in this area of telehealth triage. And he brought to our partnership many years of experience as a pediatrician, as a call center medical director, and as a writer of pediatric telehealth triage guidelines. He brought to our partnership an evidence-based, well-tested, and very robust set of pediatric guidelines. He also brought his deep clinical expertise, pragmatism, logical thinking, and just common sense. So he brought a lot to it. However, there were a number of areas in which my skills and background were different and that they complemented Bart's. My residency training was in internal medicine and emergency medicine, and I was double boarded in both. And by the year 2000, when I first started working with Bart, I had 15 years of full-time, full age range emergency department experience. I had developed a very strong interest in information technology. I participated in our hospital IT committee, wrote reporting queries on the hospital mainframe at the time, and even wrote a software program that served as an ER log, an emergency department log, to track patients. Now, when I joined Bart in the year 2000, his triage guidelines were all stored as word processing documents. I designed, developed, and implemented a relational database that could serve as a content management system for both the adult and the pediatric content. This relational database allowed us to impose a structured and standardized format to the content. It allowed us to store the content and deliver it to our software partners in a consistent and reliable manner. So that's the answer to that question.
Wonderful. That makes sense. So what role do you think nurse triage protocols play in improving patient outcomes and overall healthcare efficiency?
Well, Krista, healthcare is frankly complex from most patients' perspective. And medical call centers serve as an important access point. I think that's the key thing for ill and injured patients. Triage nurses can provide health navigation for these patients. The goal is to guide the right patient to the right level of care at the right time. Triage nurses also provide education and support for patients who may lack health knowledge or are just simply uncertain what to do. And an effective nurse triage process supports the quadruple aim, and that would be the quadruple aim of better clinician experiences, better patient experiences, lower costs, and better outcomes, so patient safety. So where do telehealth triage protocols fit into this? Well, nurse triage protocols do three things. First, they provide a structured framework or script for talking to a patient. Second, they provide decision support to the triager to help recommend the best level of care. And third, and just as importantly, they provide a evidence-based, standardized care advice to share with the patient so that every nurse that's delivering care is saying the same thing to the patient 24 hours a day. Very important.
Absolutely. Absolutely. And following up on the care advice there too, really appreciate all the work you and your team have done this year. I know our ClearTriage customers appreciate that too, and building out those care advice patient education handouts. So bravo to your team on that. So I want to talk a little bit about your editorial team. I know over the years you have focused on assembling a strong editorial team. Why has this been such an important part of your work?
It has been an important part of our work because we really consider the fact of having clinical governance a part of everything that we do. And clinical governance is a stepwise approach to ensuring that all the changes that we make to the care advice, to the triage logic, is researched, reviewed, written, tested, and then finally approved. And this is possible when one has a team of people working together in a collaborative manner. I'm blessed, or we're blessed, to have a very strong adult and pediatric editorial team. On the adult team, we've got 5 individuals. We've got Dr. Gary Marks, who serves as our medical editor on the team, and he's got a background in telemedicine, emergency medicine, and clinical informatics. We have 3 nurse editors. That's Cheryl Patterson, Janine Firer, and Courtney Book. Janine and Cheryl have an extensive, many years background in telehealth, which they bring to the table. Courtney Book and I actually first worked together in the emergency department at Northwestern Memorial Hospital, and she has many years of experience in the emergency department and also in clinical administration. So just a really excellent team that makes this work possible.
And you also work with a broader review team. How does their input contribute to improving and refining the protocols?
Yes, in addition to the editorial team, we have a clinical advisory committee of currently 11 nurse and physicians from top call centers across North America. This group participates in our guideline review process, our journal review, and provides a geographically broad perspective on telehealth. They're great. We also, in addition to our clinical advisory committee, we have established several very high-performing work groups focusing on very specific areas of content development and updating. Each work group has 3 to 5 nurses and physicians who have substantial subject matter expertise in that area. And those work groups currently are, we have a hospice work group, an oncology work group, a women's health work group, and a patient care advice topic work group, which is working on generating patient care advice that's really focused on health literacy in plain language. We're also in the process of standing up a new work group, which Lori O'Brien will be leading, which will focus on new opportunities in digital health and telehealth triage.
That is exciting. I did not know that.
Yeah.
So that I'm excited to hear that. Um, so speaking of kind of the evolving world of telehealth, so these protocols were first created, as you've said, decades ago, right? What are some of the most significant changes or improvements that you have seen over the years?
Well, decades, we'll just say 25 years ago, they've been evolving for. There have been many significant changes to our clinical content this past 25 years. For example, the guidelines have evolved and expanded as a result of changes in healthcare and public health needs.
Yeah.
For example, we have added new guidelines for MRSA, that was back in 2007, radiation exposure, 2011, concussion and traumatic brain injury, marijuana use, transgender issues, and of course, COVID-19. And I think that we made close to 18 different updates for COVID-19 over a 3-year period. Just a lot of work there. In the last several years, we've also added many new specialty-specific guidelines, plus a set of 24 hospice guidelines. 2 examples of specialty-specific guidelines would be new guidelines for follow-up of total hip and total knee replacements. In addition to this, we've added telemedicine tagging to the guidelines to facilitate handoffs from a triage nurse to a telemedicine physician or to a primary care physician who's providing telemedicine care. We have made health literacy in plain language central to the way that we write health information. And we have shifted to gender-neutral pronouns in circumstances where physiologic gender specificity is not required. Each year, the number of guidelines increases. For 2024, there were 434 adult telehealth after-hours guidelines and 364 pediatric ones. It's a big content set now.
Yes.
Just as a quick shout out, if any of the people in the audience have further questions about any of these changes, Patty Maynard, our very hardworking head of business development, would welcome hearing from you on the STCC website. So just reach out to her.
And if anyone needs Patty's contact information, as Dr. Thompson shared, that is available on the website. You can also just drop a message in the chat and our team will be happy to help you get that contact information as well. And speaking of talking with folks from the field, how do you incorporate feedback from triage nurses and healthcare professionals into those updates or changes that you make on those protocols?
Well, this is a good question. We very much welcome clinical input, questions, and suggestions from our clinical partners. Nearly every day of the week, we receive feedback from nurse and physician leaders across the country. Almost every day of the week. Bart and I and our editorial teams consider this input to be gold. We just love to get it. And in every case, we respond to every email that we get. So if you send us a suggestion, we will respond. Sometimes we may also even talk with the nurses or physician leaders by phone or by video teleconference. We answer the questions. We sometimes provide research and support, and sometimes we actually make changes based on their input. So the dialogue often results in changes and improvements to the clinical content to the benefit of all users. So that's really great. This input from nurse and physician leaders across the country is a central and maybe the most important part of our quality improvement process.
And we often, will forward you that feedback as a vendor. And so if any of you are on the call today and wondering how you can get feedback to Dr. Thompson and Dr. Schmitt and their teams, and you are a ClearTriage customer, you're more than welcome to send us that feedback and we will make sure that it gets to them, or um, I'm assuming there's a way that they can reach out to you guys through Patty directly. So, uh,
That's absolutely correct. You can go right onto our website, and there's a web form that you can use to contact us.
there you go. Okay, I want to switch gears a little bit. So we've been kind of talking about what's brought you and the team at Schmitt-Thompson to the point you are today. I want to look a little bit at the future and talk a little bit about the future of triage. So with the rise in AI, artificial intelligence in medicine, how do you see it shaping the future of nurse triage and healthcare more broadly? And I apologize that I'm asking this question because I know that we could probably talk for hours about this, but just any kind of general thoughts that you might offer today.
Boy, I agree. We could easily talk for hours about this. This is a hugely complex and very large area of possible discussion. But let's try to step into it, but speak shortly at the same time. So first, the definition. And the definition, here's the definition that I think everybody should kind of write down or remember. Artificial intelligence, or AI, is a branch of computer science that focuses on creating systems capable of, and this is the key part, performing tasks that typically require human intelligence. So that's a really good definition. AI encompasses a broad area, which can include machine learning, computer vision, natural language processing, large language models, or LLMs, robotics, and many other areas as well. In the context of medicine, AI has the potential to revolutionize the way healthcare is delivered, including telehealth triage. The integration of AI into telehealth, and this, I'm going to put this all in all caps, may be able to enhance efficiency, improve patient outcomes, and optimize resource allocation. So I'm going to go out on a branch here, but I'm going to say that AI may be more of an impetus for change, for both social and healthcare change, than the internet ever was. A couple more specifics. One of the more promising applications of AI in telehealth is the use of large language models. And these models, as you probably know, are trained on huge data sets of text, and as a result can understand and generate human-like language, making them exceptionally useful for interacting with patients, especially if it's done under the guiding hand of a good nurse triager. So I do believe that that we should explore the use of AI, and that look for ways to use AI working in tandem with this huge corpus of content that we've developed for the Schmitt-Thompson clinical guidelines, so that we can try to better aid and support the triage nurse with real-time prompts and automation of documentation. So that's a short answer to a very complex question.
It is a very complex question, and I wish we had all the time in the world to dig into that today, because I know it's top of mind for a lot of folks. But kind of a follow-up to that. So what is your vision for the future of nurse telephone triage, and how do you see the protocols or guidelines evolving to meet those emerging needs?
Um, So you're looking for a vision statement. So here's a vision statement as I kind of think out loud. We need to continue to look for ways to improve telehealth triage. We can't just do the same thing that we've always been doing. We need to evolve to make the process even better for our triage nurses. And to do this, we need to do a number of things. We need to look for ways to incorporate new technologies such as large language models and artificial intelligence to facilitate this process. We need to look for ways to capture clinical information as data rather than as a narrative of text that we store or write down. We need to look for ways to make the documentation process for the triage nurse easier, faster, and better so that we can actually reduce the length of triage calls and make the nurses more efficient as part of the process. Make documentation just seamless so that there's a seamless overlap between the documentation process and capturing meaningful data. And finally, integration of data systems is essential. We need to look for ways to capture information at the front end of an encounter, perhaps even before the triage nurse first talks with the patient. We need to look for a way to pass that data into the triage encounter in an effective way. We need to then perform triage efficiently, like we talked about in terms of speeding up documentation, providing support to the triage nurse. And then we need to, at the conclusion of the encounter, we need to capture that information again as data and pass it in a coded and structured manner to downstream users, downstream providers, such as telemedicine doctors or primary care doctors or follow-up nurses. So that's my vision of where we need to be.
I like that, and all very very relevant and meaningful points, and agree. And so, you know, we covered a little bit of the future. Again, we could go into that, I'm sure, for hours on end, but we don't have that time today. So I want to just get some of your reflections, kind of looking back. So what do you enjoy most about your work, and how has it shaped your perspective on healthcare? And then kind of a secondary question, are there any particular achievements or milestones that you're most proud of?
Well, those are frankly two different questions. In terms of milestones, I will say that probably the first important milestone was almost 25 years ago when I completed the first 50 adult telehealth triage guidelines, and I went from this faith that we could do this to the knowledge that we would be successful in this area. Another important early milestone was when Bart and I signed our first licensing agreement with LVM Systems and Epic Software, and they were successfully able to import our content from the database into their software. And now we currently have over a dozen companies using our protocols, including ClearTriage.
Absolutely.
And so the third milestone I'll mention is that every spring is now a milestone for us, because in April of every year, we publish an update to the after hours guidelines. And in July, we publish an update to the office hours guidelines. And each year, it feels like another milestone, another successful hurdle that we've accomplished. And this spring, 2025, will be our 25th update of the adult content. So that's kind of a wow. Yeah.
Yeah.
You asked me also about do we still have time? Because you asked me also about things I enjoy.
We have a few minutes left, and then I have one very important follow-up question.
Okay.
Closing question.
Okay. One surprise question. The in terms of things I enjoy most about my work, I enjoy the intellectual challenge of writing the decision logic embedded in the triage guidelines. I like that a lot. I enjoy working with our editorial team members, our clinical advisory committee, and our special work groups. It's so collaborative and congenial. It's just fantastic. I enjoy answering questions from our clinical partners and software partners across the country and supporting their good efforts. And I simply enjoy and take personal satisfaction in stewardship. That's a great word. In the context of health information, stewardship is the responsibility for creating, maintaining, and disseminating content that is both patient-centric and accurate. So that's stewardship. It's a great word. So I love this work. Hopefully you can tell.
I absolutely can, and I'm guessing that everyone else listening to this today can as well. And okay, so my last question for all of those listening today, there may be some triage nurses on this call. I'm guessing that there are actually quite a few triage nurses on this call today, many of whom probably use your content on a daily basis. You've had a direct impact on tens of thousands, if not more, triage nurses throughout the US, Canada, the world, really. Is there anything that you would like to share with them that we have not covered today?
Yes. First and foremost, I want to thank each and every one of them for the dedicated work that they do on the front lines of telehealth triage. It's awesome. Telehealth triage is an important and challenging work area for nurses. I also want to thank all the nurse leaders and physician leaders for the suggestions that they have made for improvements and expansion of our content. As I said before, this is gold, and we appreciate your input. And perhaps, Krista, I'll also thank you. Thank you very much for kind of facilitating this interview today. So thank you.
Yeah, no, this has been great. I really appreciate you taking the time to do this with us today. I feel like I know a lot about Schmitt-Thompson, obviously, working with ClearTriage or working at ClearTriage. But there are things I learned today that I did not know. So I absolutely appreciate you also taking the time to share today. And thank you to all of our attendees as well. Thank you for being with us on our first 10 for 10 webinar series. We will have our next series on February 19th. It is with the renowned Carol Ruttenberg. We are so excited to talk with Carol about decision support tools and nurse telephone triage. If you have not registered yet, you can do that at cleartriage.com/10 for 10. And we'll get you signed up and registered. If there are any other questions, please submit them before you go using the chat, and we will forward all questions on to Dr. Thompson. And then you can also email us at support@cleartriage.com if there is anything else that we can help with. So thank you, everyone. Thank you, ClearTriage team. Thank you, Dr. Thompson. Thank you to all of the attendees. This has been a great and very informative. Let's see. We went a little over. We promised 30 minutes. We went a little over, but I personally think it was worth it. So thank you, everyone, for joining us today. Really, really appreciate it.